Yeah. Okay. Okay. We can hear you. Okay. So, Dr. Vijay, before we start the session, um, we have the multiple choice question, which includes all the interventional pain procedures. So, 10 MCQs are, it has to be done. These are multiple choice questions, and it is anonymous. So, I request all of you to please tick the correct answers and submit it. We will launch the MCQs from here so that all of you can see the multiple choice question. So, Dr. Vijay, is it okay?
Sorry, I didn't get your question. Actually, the MCQs have been sent out. Is that?
Yeah, yeah. First of all, we will ask the participants to do the MCQs. It's an online survey, so that it will take about maybe 5 minutes at the maximum, and we will start your session after the whole of MCQs.
After that, yes, yes, sure, yeah.
Okay. So. So I hope all of you can see the MCQs. So just click the right answers, and after finishing the 10 questions, you can see the end polling. So just click on the end polling. This is anonymous. So I request all of you to do, please, please do the MCQs.
చెప్పలేము 4 వారు కొంతలో ఉంటారు. పేషెంట్లు ఎవరు లేకపోతే వెళ్ళిపోతారు. పేషెంట్లు ఉన్నారనుకో 5 వరకైనా ఉంటారు.
Dr. Sunil?
Yes.
4031.
Yeah, yeah. Just tell me, Dr. Vijay.
The last question is actually a negative one. Is not due to the question
Okay.
for all the participants. I think I made
Okay.
a mistake.
Yeah.
It's not the 10th, the last one.
That we will correct for the post-poll session after completion of all the session.
Yep.
So, have you completed? Anybody is doing now? 7 of you have completed. 8. Now 8. So we will stop this call within 1 minute. Okay, I think, yeah, most of you have completed. We will end the poll now and we'll continue with the Dr. Vijay's session. So, our first session on interventional pain management is interventional pain management in peripheral occlusive vascular disease by Dr. Vijayanand. Dr. Vijayanand is a well-known pain physician, and he has been helping us with previous sessions on pain also. So he's a very busy physician. So I thank him for giving us time to conduct this echo. And I request Dr. Vijay to present his PowerPoint. So we will share the PowerPoint.
इसमें दिक्कत हो रही है तो इसमें देखो फिर.
So I request all of you to please mute the microphone. Dr. Vijay, can you see?
Yes, I can. Yeah. First up, good afternoon, everyone. And it's, I think I know a few names on the list. Dr. Anjum, Megha, Gaurav. So everyone who knows me already, very sort of my regards and a hi from Coimbatore. So we're going to talk about interventions in peripheral occlusive vascular disease. It's going to be a brief presentation, just kind of touching upon the most relevant aspects from a clinical perspective. So I'm not going to sort of delve in depth in terms of anatomy, physiology, and all sorts. So how do I change the slide? Is it? Can you change the slide? Yeah. So the intervention, we're going to talk about a couple of interventions which are quite useful for peripheral arterial occlusive disease or peripheral vascular occlusive disease. And those interventions are the stellate ganglion block and the lumbar sympathectomy. Now, these injections, generally speaking, are used for different purposes. Actually, can be used for diagnostic purposes. You know, whether blocking the sympathetic nerve supply could actually help the peripheral vascular disease. It can be used for prognostication as well, in terms of whether this patient might go on to benefit from a surgical sympathectomy if required. And on many occasions, we use it for therapeutic purposes. When I talk about therapeutic purposes, it is about putting in some neurolytic solutions like phenol or alcohol to destroy the sympathetic plexus or the ganglion, which is a stellate in the lumbar sympathetic plexus. sometimes we use what we call the radiofrequency ablation, where we can pinpoint and burn those ganglion or the plexus. Now, if you look at the second point on the slide, it says useful in arterial insufficiency, but not venous insufficiency. This point should be made very clear, actually. It's not of much use at all when there is venous insufficiency. And I've underlined that useful, not because it is very useful, only because we don't know, or I don't know how useful it is, actually. It's a very honest sort of a price, because we do quite a bit of these lumbar sympathetic blocks, we do quite a bit of the stellate ganglion blocks. Generally speaking, the efficacy is a little bit, or the effectiveness is a little bit mixed. But if you look at the history, how long these injections have been done, it's for quite long, actually. It's got a long history. It's more than 100 years we've been doing this, or blocking these sympathetic nerves. And you would imagine that if you've been doing this for such a long period of time, then by now we would know exactly which patient to choose and which patient to do. But we're still a little bit in the dark, actually, because if you look at how well the celiac plexus, the stellate ganglion block works for upper limb arterial insufficiency, or the lumbar sympathetic block works for lower limb arterial insufficiency. The effectiveness, clinically speaking, it is mixed. If you look at efficacy, which is kind of looking at an ideal situation where you monitor everything, then that's a slightly different story. But if you look at effectiveness, which is looking at a real-time sort of situation where you perform the block and see whether it works or not, it is a mixed bag, actually. And if you look at, people always ask, what evidence there is for a stellate ganglion block to work well in an upper limb insufficiency. It's not great, actually. And if you look at lumbar sympathetic block too, it is not much. You're looking at evidence what we call 1C, which means there are not proper randomized controlled trials or blinded studies to suggest that this is it and this works. So it's a mixed bag. So coming from an interventional pain perspective, you should understand that yes, there are situations where it works really well or reasonably well, and there are situations where it doesn't. And this whole afternoon, I'm kind of trying to tell you about in which conditions it is good to refer patients and who might benefit. Now, before doing that, we're going to briefly look at the anatomy and briefly look at the physiology. Just a few slides, a few minutes, just to get you up and running with regards to what we're going to do, mainly the stellate ganglion block for upper limb peripheral vascular disease and lumbar sympathetic block for lower limb peripheral vascular disease. Next slide, please. Okay, so this image, it's a fairly sort of a straightforward one. You look at the thoracic sort of vertebral column, and you can see the spinal cord sitting in front of it. It'll be nice for me to have a pointer, but I think you should just kind of quickly go through the different. Basically, you've got dorsal and ventral roots from the spinal cord, and you have the dorsal root ganglion. And the sympathetic efferents arise from the spinal cord. It travels up the ventral root through the white rami communicans. It enters into the sympathetic trunk, the ganglion. You can see a chain, about 5 sort of little balloons hanging at the side of the thoracic vertebral bodies, and that's what we call the sympathetic trunk. Some of them synapse at the same level, some travel up, some travel down. Some of them do not have a synapse at all and just crosses over as splanchnic nerves, the thoracic splanchnic nerves. And these are the nerves which we kind of do radiofrequency ablations in chronic pancreatitis. It is catching the, even before it reaches the celiac plexus, it is catching, these are all the preganglionic fibers. And it is like a chain on both sides. And it doesn't end there, though it is distributed to the thoracic, though they all arise from the thoracic part of the spinal cord from T1 to probably L1. The chain itself extends beyond or up cephalad into the cervical region, and also extends caudad, up to the coccyx. When we do the ganglion impart injection for cancers or tumors lower down, that is the sympathetic plexus what we burn. So this is just to get you up and running with the anatomy. Next slide, please. Okay, this is just a line drawing. You can look at the purple line, and that is the sympathetic efferent arising from the spinal cord, and it kind of travels via the ventral route. You can see how it curves. It enters through the white rami communicans into the sympathetic ganglion itself, and the orange is the postganglionic neurons. And these neurons go on to synapse to make a plexus at different levels. You have the celiac plexus, you have the superior hypogastric plexus, you have the ganglion empire, all sorts of things. Okay, so these are the postganglionic neurons. You can see the targets of the skin, the blood vessels, the muscles, and the glands. And the next slide, please. The whole idea of doing a sympathetic block is based on the premise that if you can improve the blood supply to the peripheries, then that could relieve the pain. So this is the whole idea. Now, before we go into look into the physiology, now how much it actually helps from improving the blood flow perspective, it is useful to quickly go through the anatomy a little bit more. So for the lower extremities, it originates from the spinal cord segments T10 to L3. This is the spinal cord segments, okay? But if you want to block the ganglia, it is looking at L2 and L3. So that's the second point, which is usually there are 3 lumbar ganglia, the L1 and L2 are fused, and it's the L2 and 3 levels where you want to go when you're doing the lumbar sympathectomy. Okay, and for the anatomic completeness of the sympathectomy, it is essential to minimize the regeneration. Now, the thing is, we can't do much. You know, you can only go in and stun those nerves, you burn those nerves, you put some chemicals and destroy the nerves, but how quickly it regenerates, it's not under our control. But most of the times when we do the block and we kind of come back and start scratching our head, you know, why it's not working, it means that it has not been destroyed completely, or the patient selection has been absolutely wrong. So there are 2 things. One, you have to choose the patient appropriately, adequately, prepare them, and then do the procedure. And doing the procedure has to be in a very, very controlled manner, and make sure that we do the maximum damage to the plexus to stop to increase the blood flow. And the other point to make is increasing the blood flow doing a stellate or a lumbar sympathectomy doesn't always mean that that is going to reduce the pain. So you can have fantastic blood flow back in the limbs, but the limb could still be painful. Okay, next slide, please. Now we're going to look at the stellate ganglion block in the next slide. Okay, so this is the upper limb. This is the stellate ganglia. So the cervical sympathetic, though it arises from T1, T2, T3, the ganglion sort of extends up into the neck. So you have the superior cervical ganglion, you have the middle cervical ganglion, and the inferior cervical ganglion, which combines with the thoracic to form what we call the stellate. So if you want to sort of improve the blood supply to the head and neck, or you want to treat any pain conditions to the head and neck, it is the T1 to 5, which is ascending in the sympathetic trunk. And if you want to treat the lower limb, which is the upper limb sort of vascular insufficiency, the origination is from T2 to T6, but it all kind of gets onto the stellate ganglion, which is an easy target. Okay. Next slide, please. The next slide is quite important because we're going to look at the physiology and understand a few things, actually. Now, if you do a sympathetic block in a normal person, say if they do a sympathetic block in me, if I get a lumbar sympathectomy done or a sympathetic block done, I could clearly demonstrate that my leg has become more red because there is much more blood flow. It is going to be a little bit warm than the other leg. Okay, so in a normal condition, it seemed to work pretty well. But if you do the same on an extremity, which is affected, where is an occlusive arterial disease, we don't really know actually what is the mechanism and how much blood flow is going to be increased and things like that. So there are a few sort of physiological set of points I would like to bring to your notice. I think most of these points have been covered in the multiple choice questions. In case you're wondering, whether what to answer and what not, there you have the answers. So when we do a sympathetic block, we are basically abolishing the vasoconstriction, which means the vessels are nicely vasodilated and the blood starts flowing into the peripheries. Okay, this is fantastic. But there is a catch there because there is a shunting in the peripheries. Okay, blood flows from the arterioles into the capillaries and back to the venules and then back to the heart. Whereas in the peripheries, there is a shunting happening because it doesn't necessarily enter into the capillaries. It gets shunted from the arterioles to the venules, which means the tissue perfusion is still a little bit dodgy, actually. The pain, the ischemic pain is because of tissue perfusion being much less. Doing a sympathectomy doesn't necessarily improve the tissue perfusion. Okay, and this is also quite an important point to make. And there is also a temporary and a significant increase in collateral blood flow. Say, if the blood flow increases by 100 ml into the limbs, at least 10 to 15 ml of blood is because of the collateral increase in flow through the collaterals. And the relief in ischemic pain is also due to reduction in the painful sort of stimulation, because it not only affects the vasculature, it also affects the pain transmission per se. And the relationship between the lumbar sympathectomy and the pain threshold is also something. It actually increases the pain threshold. So there are a lot of important points there to note. When I say it doesn't necessarily improve the tissue perfusion, the point to sort of extrapolate from there is it might help with the rest pain, the ischemic pain at rest, but it does not necessarily help with the pain during claudication. Now, this is a very, very important point, because if you speak to people suffering from vascular diseases, the typical complaint they have is claudication. They walk for some 100 meters, they have to stop because the blood flow is much, much reduced and it's much, much painful. Now, in those patients, if you do a lumbar sympathectomy, it doesn't necessarily help. In fact, it doesn't help at all, actually. It helps the rest pain only, not the claudication pain. This is very important. Keep this in mind, because when you discuss the case report, which is going to be presented, it is a very important point to note. And also, if the pain is neuropathic, say, for instance, in a vascular damage, it is the same blood vessels which are going to supply the nerve as well. So there's a vasa novorum is there. And if that blood supply is compromised, and if there is neuropathy, then doing a sympathetic plexus block doesn't necessarily help. So if it's a predominantly neuropathic pain, it doesn't help. If it is a predominantly claudication pain, it doesn't help. So two important points to remember. And these are important points when the case decision comes up as well. So next slide, please. Okay. So these are the three main indications. So if you look at textbooks, normally they kind of try to get information from all over the place and start putting things. You can do it for migraine, you can do it for this, you can do it for that. Never mind for refractory angina or whatnot. But these are the three main sort of indications where you would like to do a stellate or a lumbar sympathectomy, which is complex regional pain syndrome. The second one is what is of interest to us today, this afternoon, which is inoperative arterial occlusive disease. With limb-threatening ischemia causing rest pain with limited ulceration. Now, that limited is a very, very important adjective to keep in mind, because if you do have a large gangrene, a large ulceration, or a big tissue damage, then it is unlikely to help. So this is the third point. So if someone's got a big ulcer, and if you refer them to get a lumbar sympathectomy done, it is unlikely to help with the ulcer healing, nor with the improved blood supply. And other symptomatic vasospastic disorders, by that I mean things diseases like Raynaud's and frostbites and so on and so forth. So these are the main sort of indications. There are 100 other things for which we do these stellate blocks, and we do the lumbar sympathectomies, but those are pretty rare actually. These are the common sort of conditions for which we do that. Next slide, please. Okay, so if you want to do a lumbar sympathectomy, so apart from looking at whether there is a big ulcer or not, whether there is claudication or not, in which case it doesn't work, there's also something to think about, the ankle brachial index. Now, this is which should be greater than 0.3. If it is less than 0.3, it is unlikely to help. Now, how do you do the ankle brachial index? It's a very simple thing. You just ask the patient to lie down quietly for 10 minutes and then measure the ankle blood pressure, take the systolic of the ankle blood pressure, measure the blood pressure in the brachial arteries, take the systolic of the brachial, and you divide the ankle by the brachial. And if it is more than 0.3, with no claudication pain, with no big ulcers, then it's likely it is going to help. If it is less than 0.3, it means there's a significant reduction in blood flow to the peripheries, and your sympathectomy, either stellate or the lumbar sympathectomy, has minimal chance of helping you. Absence of neuropathy. This is again, it's a very, very important point. If someone's got allodynia, a light touch triggering off the pain, the fan air blowing across the skin triggering off the pain, it means that the nerve itself is damaged. Now, when the nerve itself is damaged, then again the lumbar sympathectomy doesn't help. And if at all you're going to do what we call a permanent or a semi-permanent procedure by putting in some chemicals like phenol or alcohol, are you going to stick in a radio frequency needle and burn that nerve, then we have to demonstrate clearly, just by putting some local anesthetic, that the pain is relieved. So you have to get some symptomatic relief by doing a trial block. So we can't do a permanent or a semi-permanent procedure just like that. So we have to demonstrate that blocking the sympathetic plexus, the stellate ganglion and the lumbar sympathetic plexus, it actually helps. Now, the relief of rest pain is expected in significant number of patients meeting this criteria. As I said, it doesn't help with the claudication pain. And when there is tissue loss, it should be restricted. If it's a limited ulceration, only a single-digit gangrene is present, then it is fine. You can expect some healing as well because there is improved blood flow. But if it is a big ulcer, then it is unlikely to help. And it's also useful for Raynaud's and frostbite too. This is with regards to the lumbar symptom. Next slide, please. Okay, so in which patients you shouldn't do? No, we have chosen our patients. We know who can possibly benefit from these procedures. And these are the patients who we should never send them off to get a stellate ganglion or lumbar symplectomy done. One is the anticoagulated patients, or those with coagulopathy, and obviously it's going to bleed like hell. So if you're going to stick a needle in the neck, where you have the sort of big vessels sitting, the carotids, the internal jugulars, you have the vertebral artery, you have the thyroid artery, and whatnot. So it is best to avoid it in patients who are anticoagulated or who are having a coagulopathy. And when it comes to stellate ganglion, the lower sort of three bits of information is quite important. If someone's got a recent MI, you wouldn't want to go and start sticking needles in their neck. Glaucoma, again, it makes it worse. And if there is a phrenic nerve palsy, now the phrenic nerve, you all know, it kind of controls the diaphragm. And if the other side is paralyzed because of phrenic nerve palsy, and then you block the opposite side, then both diaphragms stop working and patient gets quite dyspneic. So, these are situations where you have to avoid, I would call it contraindication. So we looked at the indications who might possibly benefit from these sympathetic blocks. And this is a group of patients who it shouldn't be done. So again, it's a group you can exclude if you want to refer someone to get a sympathectomy done. Next slide, please. Okay, so we're going to look at the technical bits in a very, very sort of brief while. You can look at the picture. It's just a line diagram. You can see it number one, which is the aorta. Number two is the IVC, inferior vena cava. Number three, in the lumbar symplectomy, is the vertebral body. Number four, you could see, is the kidney on both sides, so kidneys, plural. And number five is the vein. So you can see that there is a thread sitting, one on either side. Vertebral body. Okay. So next slide, please. So this is how you position the patient. The patient is prone. It is typically done under fluoroscopy or done under CT scan guidance. Now the stellate ganglion, you could do it under fluoroscopy, you could do it under CT scan, or you could get it done under ultrasound guidance. But lumbar sympathectomy, ultrasound rarely reaches the sympathetic plexus. So they are prone. So you take an oblique and a little bit of a cephalocauda tilt of the C-arm so that you can see the vertical. So next slide, please. Okay. So this is again is a line diagram. You could see the needles. You can see the needle on the right of your screen, and it is kind of quite straight up actually, and it doesn't reach the sympathetic the lumbar plexus, as you can see. Whereas if you approach it from a slightly oblique angle, then you can see the tip of the needle is quite close to the sympathetic ganglion, and you can see all the other structures too, and you can see the muscles through which you have to go through. You have the erector spinae muscles, you have the psoas muscles, and we have the quadratus lumborum, the latissimus dorsi. There are a lot of things to have in mind when we're doing this procedure. Now, previously, at least 15, 20 years ago, when I was doing the anesthetic training, the teaching, particularly in India, is to take a 4 fingers breadth away from the midline and you stick a needle. Now, in this day and age, it is completely sort of unacceptable for someone to do a lumbar sympathectomy or a stellate ganglion block without imaging procedure, because you could easily puncture the kidneys doing a lumbar sympathectomy. It doesn't really matter if you puncture the kidney and realize that you're in the kidney, but if you inject alcohol or phenol into the kidney, then that becomes a major problem. So it's kind of a very important to use an imaging technique for this. So next slide, please. So this the next slide, yes. I'll show what it looks on the X-ray. So this is what it is. The image to your left is the lateral view, where you can see the tip of the needle is very, very close to the anterior border of the vertebral body. And you can see the dye, which is contrast, which is spreading up and down. And the image to your right is a typical AP view, where you look at the needle is sitting in relation to the pedicle, and then you can see the dye spreading up and down. Now, this is a nice position to place the needle. And at this point, what we would typically do is to inject some local anesthesia. Probably 5 mils of local at the level of L2 or L3 is where we enter, and then wait for some time. So what I typically do in my own practice is to measure the temperature in the distal in the toes, and if the temperature climbs up by at least 1 degree Celsius, then it means that we've done a decent block. And if the patient also says that yes, my pain is slightly lesser, then that is an indication where we can either go and keep the needle there and put in some alcohol, 5 mils of alcohol, or you put in 6% phenol, 5 ml, and that should do the trick. So this is doing on one side. Now, if you do it on both sides, it becomes a problem, because there is a chance of retrograde ejaculation, there is a chance of impotence and things like that. So again, this is an important point to have in mind, because when it comes to the case discussion, it's a very, very interesting case we have today. So this is an important point. If you have bilateral claudication, bilateral sort of peripheral vascular disease, this is not a block you would like to think about, because if it's a young person, then impotence is going to be a major problem in his life. Next slide, please. So now we're going to look, from the next slide, we're going to briefly look at what a stellate ganglion block looks like. This is looking at your neck vertebra from the front. So you have the cervical vertebra C1 up to C7 and the T1, and you can see these kind of like a grape-like structures dangling on both sides. And if you trace the grape-like structure right to the bottom, you have the stellate ganglion on the left side, which is the sort of the lowest cervical and the upper thoracic combined to form the stellate ganglion. It is not a huge structure. It is about 2.5 centimeters long. It's about half centimeter in thickness, and it sits just on top of above the longus colli muscle. And as you could imagine, there are a lot of important structures there, so you can do a lot of damage trying to do a stellate ganglion block, and we will have a look at what damage you could do later, but I'll just quickly go through the procedure itself. Next one, please. Okay, so this is how we position the patient. I'm just going to show you briefly how we do it under C-arm. So the patient lies supine, and then you place the C-arm, just straight AP without any oblique. Next slide, please. And this is how we insert the needle. So you retract the sternocleidomastoid, make sure your carotids and your internal jugular veins are away, and then you do the injection. Next slide, please. So next slide will show you what it looks like on the X-ray. So this is what it is. So you can see the tip of the needle. It is at the junction of the body and the transverse process, and they have actually injected some contrast, which is spreading up and down. It is actually at the level of C6, where you see the Jasayanax tubercle. Now, they say though the ganglion is at the level of C7, if we go chasing the ganglion down to C7, there is a very, very high risk of pneumothorax, because the dome of the pleura just lies in front of that. So it is better to go at C6 and put in a slightly larger volume than go aiming for C7, where you could easily introduce a pneumothorax. Next slide, please. Okay, the next slide is what it looks like in an ultrasound. I think if there are anesthetists in the group, they might be quite well versed with the use of ultrasound. So this is what it looks like. There's a colored sort of image, what it looks like under ultrasound. So if you look at the left part of the screen, you have the trachea, you have the esophagus, which just lies underneath the trachea. You have the thyroid sitting in the front, you have the carotids, the jugulars. Now basically the entry point is from the side, between the jugular vein and the vertebral artery, and it just lies in front or above the longus colli muscle. So if you're going to do it on the ultrasound, this is the approach we have to take. So you do the block, and the next slide, please, and that's what the patient looks like, which is the next slide. Okay, so this is what we get after the stellate ganglion block, and this is what we call the Horner's syndrome. Now, it is usually, it comes into the list of complications when we do a stellate ganglion block. For me, it is not actually a complication. For me, it is an indication that I've kind of put the local anesthetic in the right place. Here you can see to your right, the eye on the right side of your screen, you have ptosis, the eyelids are drooping. You have meiosis, the pupils are tinier. You have anhidrosis, which you can't really see, which is reduced sweating, and what we call the enophthalmos, which is basically a sunken sort of eye. In thyroid, hypothyroidism, you see what's called the exophthalmos, where the eyeball pops out. This actually sinks in. So this is an indication that we've actually blocked the stellate. So this is how we do the stellate ganglion block and the lumbar sympathectomy. So we'll kind of briefly look at the complications. So we looked at a brief look at the anatomy, a brief look at the physiology, a brief look at who can benefit, a brief look at who shouldn't be, who shouldn't have this procedure done. We looked at how the procedure is done. And now we look at what are the complications. Next slide, please. Okay, this is something which I already talked about. Next slide, please. Okay, so if you do this slide is more about lumbar sympathectomy complications. We'll talk about the stellate next. The most common complication, they talk about a lot of things. You can puncture this, you can puncture that, but this is what we see clinically. It's the post-sympathetic neuralgia. At least half of them have this anterolateral thigh pain, which is quite worse actually at night time. But normally they respond to painkillers, and normally the pain resolves in a couple of months' time. So there's nothing much to worry about, but it's just this nagging pain which is there. Impotence is an issue, particularly when you're doing bilateral sort of lumbar sympathectomies. The second most complication is to not achieving the desired objectives, which means a lot of people do not benefit from lumbar sympathectomy, right? And that lot of people is because we haven't chosen it well, we haven't chosen the patient well, or we haven't done the procedure well enough. So next slide, please. Okay, so this is a complete list of complications. This can happen in both stellate as well as lumbar sympathectomy, but it is much more sort of important when it comes to stellate ganglion block. So you can easily damage the vasculature in the neck. So you can puncture the carotids, you can puncture the internal jugular vein, you can puncture the carotids, IJV. You have the vertebral artery, so you can end up with an infarct. Spinal cord, if you can do some damage to that. And you also have what's called the supine serpentine, or the inferior thyroid artery, which you can damage, causing some necrosis. So you can do the damage, you can cause a hematoma, but you enter the vessel, and if you inject the medication, which is a local anesthetic, then that becomes a complication as well. People can have cardiovascular arrest, they can have seizures, they can slip into coma. You can damage a lot of nerves, and we looked at the phrenic nerve. It's a very important thing where you block the phrenic nerve, that diaphragm gets paralyzed, and so it is people might have some dyspnea by the end of the stellate ganglion block. So if someone's got dyspnea following stellate ganglion block, there are two things which should come to your mind. One is whether we block the phrenic nerve. Two is whether we give them a pneumothorax. So if they're finding it difficult to breathe, okay. And also recurrent laryngeal nerve, they start speaking funny after the procedure. There's a squeaky voice, because that's the thing which the recurrent laryngeal nerve controls your vocal cord. So they might have some squeaky voice for a little while. It is okay if you're just going to put in some local because it wears off. But if you're going to put in some alcohol or phenol, then it becomes very important, because they will be left with a permanently squeaky voice. And then you have the neuraxial structures. You can inadvertently, you might enter into the intrathecal space, you can enter into the epidural space, you can do all sorts of things. And there are a lot of other structures you could damage. You can damage the lung, you can puncture the trachea, you can puncture the esophagus, and cardiac complications is quite important. I used to do hundreds of these when I was doing a fellowship with the Refractory Angina Center, where we do a lot of them, 15, 20 every week. And it is very important because it causes bradycardia. When you put a local anesthetic close to the stellate ganglion, it causes bradycardia. And if someone is already bradycardic, it can sort of end up in a complete heart block. So it's a very important thing. And also the risk of infection. With any interventions, you can introduce a soft tissue infection, you can introduce a meningitis, you can introduce a bone infection like an osteitis. So these are the complications. So I think we have covered pretty much of the two most important interventions you could offer for a peripheral vascular disease, and who to do, whom not to do, and things like that. So, so thank you very much.
Thank you, Dr. Vijay. It's that time for doubts. Anybody want to ask? So we see we get a lot of references from surgery for chemical lumbar sympathectomy. It's usually the lower limb thing that we usually get, not upper limb. So, what is I have heard about steel phenomena during chemical lumbar sympathectomy. Can you explain what is steel phenomena and how to choose patients for? You have already
chemical sympathectomy. What would you?
Yeah.
Sorry, the audio is breaking. I'm kind of having interrupted sort of audio here.
Okay. I will ask. If we do chemical lumbar sympathectomy, if the patient has large vessel blocks, it will produce steel phenomenon. So, can you explain what happens and why it should not be done if the patient has large vessel block?
I'm sorry. I think it's my internet which is unstable. I'm sorry about that. It's very broken actually. I'm not able to kind of. Maybe someone else can.
Vijay, can you hear me?
Hello. Else in the audience want to try? I don't know if it is my internet or the other side. Yes.
Vijay, can you hear me? Hi. Hello.
Yes.
Yeah, so I'm Dr. Nandini. I just want to repeat what Sunil was. There is major vessels. How do we select the right patient so that there is no steel phenomena and the whole procedure is ineffective? Have you seen steel phenomena, and are there issues that you have faced often?
Hello.
Yes. We were talking about steel phenomena.
Steel phenomenon. Yes, I saw that. I mean, there are two. Can people hear me well? Because I have a doubt that it is my internet which is playing up. Can you all hear me well?
Now it's okay.
Okay. Now there are two issues which with regards to the sympathectomy. One is what we call the steel phenomenon, and then the other one is the ischemia reperfusion injury. So what happens is you block the lumbar sympathetic plexus, and that improves the blood supply. Now you have a limb which is being devoid or is being denied blood supply for quite some time. So the tissue is packed with chemicals, particularly lactic acid and a lot of other sort of chemicals. So if you do a lumbar sympathectomy and suddenly improve blood supply, it means that that sort of soup of chemicals which is sitting in the leg is going to get washed back into the system. So that could be quite sort of dangerous actually in terms of causing cardiovascular and CNS side effects. And the other issue, obviously, if you suddenly, this is what they're alluding to from the steel phenomenon, if you increase the blood supply, that might sort of put an immense pressure on the heart as well, because suddenly there is a blood rushing through to the periphery. So, which means you tend to have fluctuations in blood pressure. But I mean, from a clinical perspective, we kind of very rarely observe that, at least from my experience. Not that I do many, but what little I have done, it is rarely we see that.
Yes.
Hello. Hello.
Okay. The next question I have is, how long does it work? Okay, so the next question I've got is, how long does this work? Now, I don't have very good news for you. It doesn't work long at all, actually. The thing is, if we're going to do a lumbar synthetic plexus block, it lasts as long as the local anesthesia works. But if you're going to do a neurolysis by putting in some alcohol or by putting in some phenol, the thing is, okay, the vasodilation, it works maybe for 2 to 3 weeks. But after that, it starts to wear off, actually, because the blood vessels, they find their own new normal. And so that's a problem, because in many people, pain starts coming back 2, 3, 4 weeks later. So which is a major challenge, actually. So in terms, if you ask me whether it is cost effective, it depends on how much you're charging the patient, because generally speaking, the pain relief lasts for 3 to 4 weeks. But sometimes, with a bit of luck, if it's a patient who's been chosen pretty well with just the rest pain, minimal sort of ulcer, so you go in, you do the lumbar synthetic neurotomy with phenol or alcohol, it sometimes lasts longer, actually, maybe 6 months up to a year. Now, if you look at what other options we have, you can do an open symplectomy. You can do a surgically, you can go in and cut the nerves and come back. And that kind of surgical symplectomy seemed to help for 2 years maximum, which means eventually the nerve starts growing back, right? And the regeneration starts pretty soon, actually. And that's the reason why these procedures are mostly short-lived. It might last for a few weeks, maybe a few months. Generally speaking, we see 2 to 3 months maximum they benefit from these procedures, and after that, either they get better, or their pain comes back, or they end up with an amputation.
Dr. Iqbal?
Okay, what strategy do you use to keep patients on steroids? Okay, so I think if there is one thing which is really going to help these people with peripheral vascular diseases, it's particularly the TAO, the thromboangiitis obliterans sort of conditions. The one thing which is really going to make a difference is smoking. So if you're going to stop smoking, that's going to kind of reduce the pain. And the other thing is these, it's probably a disparaging term, but sometimes we call them the vascular pads. So if you have a peripheral vascular disease, it is also highly likely that your cardiac blood vessels are also going to be sort of atherosclerotic. So you're sitting duck for myocardial infarctions and whatnot. And which again, the risk factor is smoking. So, I mean, what strategy do I use? I mean, you can use the usual sort of counseling and whatnot. You can also think in terms of nicotine replacement therapies like patches and gums, just for them to wean off smoking. But I think, I mean, eventually they have to stop smoking, and there is not much we can do, actually. Say if someone who's 85-year-old with a peripheral vascular disease, he smoked all through his life, and if that limb is not salvageable, I think he's never going to stop smoking. So you might as well get his limb amputated than stop smoking, actually, because that's what he's done all along his life. So it's a tough one. I think we have to involve the counselors and get things going.
Hello.
Yes.
Hello, sir. Sir, is there any role of styloid ganglion block in head and neck cancer, sir? Not relieved by any other big neck nodes causing severe pain. Is there any role of styloid ganglion block, sir?
Yes. What other blocks can I do, you're asking?
Yeah. Is
what
there
other
any
interventions I use?
Yeah, intervention for head and neck cancers.
Head and neck cancers. Okay. So we are looking at two important interventions for head and neck cancers. What we do. stellate ganglion rarely helps in head and neck cancer. It helps maybe for upper limb muscular pain. Sometimes they use it for migraine, but we do two important things. One is trigeminal Gazerian ganglion ablation, where you go and ablate the trigeminal nerves. And if it is atypical, then we do what's called the sphenopalatine ablation, where we go through the pterygopalatine fossa, get to the sphenopalatine ganglion, and then put some alcohol or phenol. And they seem to work maybe for 2-3 months. At least they have some comfortable sort of. The thing is, the trick with these head and neck cancers, I mean, they're not particularly painful to start with. By the time they're painful, they're pretty advanced. And this is where the challenge is, because the anatomy is distorted. I mean, luckily, if there is no bony sort of infiltration and bony damage, we could still get to the foramen ovale with the C-arm, with the fluoroscopy. You can still see the pterygopalatine fossa through the fluoroscopy. So we have a little bit of, I mean, very often what we also see is the intracerebral sort of tumors, all these meningiomas and all these glioblastomas. They also try to grow out the foramen ovale. So the thing is, they sit there blocking your sort of entry into the close to the Gazerian ganglion. So it's tricky actually. And if at all I'm going to do it, I would like to have a look at the recent MRI scan to see whether the tumor tissue is sitting in the pathway where the needle is supposed to go.
Thank you, sir.
So in terms of, there's another question with regards to the vasodilatory drugs. I mean, that is the first line of treatment, isn't it? So you would like to use the usual sort of calcium channel blockers and whatnot. They're quite sort of useful, particularly the amlodipine and things like that. And you would also like to use drugs which might improve the blood flow, like the pentoxiflin, the improve the rheology, and also other medications which will stop the embolic phenomenon like warfarin and aspirin and whatnot. But the first sort of port of call is to use the vasodilatory drugs to see if you can improve the blood flow, and maybe some simple painkillers till those vasodilatory drugs starts working. And if that doesn't, and if he doesn't have a big ulcer or a claudication pain, is when you start thinking maybe a lumbar sympathectomy.
How frequently can we do the chemical lumbar sympathectomy?
How frequently?
Yeah.
I suppose you can do it every 4 months, every 3 months. It is possible to repeat. But it will be technically, there will be a problem, because if you're going to do a chemical neurolysis, so we do it once, we put in some phenol, put in some alcohol, and do a neurolysis. That 5 ml can spread quite a bit actually, which means that part of the tissue is going to be fibrosed after the first injection, right? So if you're going to repeat it after 4 months or after 6 months because the pain has come back, so you go through into the same place and you inject the alcohol or phenol, it doesn't necessarily spread where you think or where you want the drug to be spreading, because it's all fibrosed. It might direct the chemical away from where you want it to spread. It may be one reason why it is not effective, not because your procedure was technically wrong. It is because the tissue is already fibrosed and the drug is not actually getting to the lumbar sympathetic plexus.
Okay. Anybody else? So, shall we move to the case presentation by Dr. Iqbal?
Now, do you want me to stay for the case presentation?
Yes, if possible.
Sunil, is it a peripheral vascular disease? Then I think, Sunil,
Yeah.
is the patient having some kind of...
Yes.
Okay. Then if it's possible, Dr. Vijayanand, please stay back.
Please stay, sir. Vijayanand, sir.
Yes, I'll stay back.
Thank you so much.
I saw Mary Abraham, madam, on the other camera. Hello, ma'am.
Hello, I'm sorry, I was busy. Sorry. Hello. I was busy with a case. I just joined. I'm so sorry for being late.
Good afternoon.
Good afternoon.
No worries. Good afternoon.
So, Dr. Iqbal,
Yeah.
please proceed.
Hello. Yes, thank you very much, Sunil. I would like to thank LM India for giving me the opportunity to present this small case, which I have seen 2 weeks before back. And also, I'd like to thank Dr. Vijayanand for staying with us. I think he will. So, can I have the next slide? Yeah. So this gentleman, 16-year-old, he presented is a smoker, long-standing smoker, farmer by occupation. She came in with severe pain, 10 by 10, on in the bilateral feet, and left side is more than the right side, which is 1 year of duration. Now the pain was burning in nature, and sometimes it is like something like electric like sensation awakens him at night. And he typically complains that on walking for about 90 to 100 feet, which I have asked him, he develops too much pain in the lower limbs, that is feet and the calf muscle, and he has to stop and rest for 1 to 2 minutes. Now again, walking, then again this resting time increases more and more on subsequent walking. That means again he has to rest for 3 minutes, 5 minutes after walking every 90 or 100 feet. Next slide. Now he complains of an ulceration in one of the fingers of the left feet, and his sleeps is disturbed, and he is depressed, and sometimes he severely cries in pain, and it has affected his activities of daily living. Next slide. Now this is a photograph which I have taken just yesterday because Seva told me to present this case, So I was lucky to have this present photograph yesterday. She just presented with a non-healing ulcer, and I think it's just impending gangrene after some time, up to some period of time. Next slide. Then on examination, I could see that there is some skin changes in the that left foot fingers. There is some atrophic changes. There is loss of extremity here, and there is thickening of the leg, and there is some difference in the temperature between the right and the left one. The left one big little bit colder, and both the dorsal, I could not palpate both the dorsalis pedis artery. Next slide. And I thought of putting a pulse oximeter bilaterally, and I found that pulse oximeter in the left limb, it does not show anything, no pulsatile waveform, and on the right side the pulse oximeter shows 93% saturation and pulse of about 75. Just for correlation, I have done this. Next slide. Now sorry for this CT scan, I could not write it. My Dr. Pial, our radiologist, has reported. You can see that there is atherosclerotic changes in the distal abdominal aorta, narrowing in the distal abdominal aorta, both the common iliac artery, external iliac artery, bilateral there is narrowing, and there is low velocity flow in the both the lower limb arteries. Next slide. This is the Doppler study. Now on past history, the patient was hypertensive. He was on some medication. He was taking amlodipine tablet 5 mg COMD, and he was on pentoxifylline sustained release tablet 400 mg twice a day, and he was on tramadol 50 mg twice a day. Next slide. Now I could not elicit anything about any psychosocial problem in this patient. There is no past family history of any psychosocial problem. And next slide. Now, this patient came to me. He is a very good, the performance status is very good. And he came to me because nobody could control his pain. He was moving here and there for 1 month. So he heard my name and just came in for pain relief. But so I continued pentoxifylline 400 milligram BD, then started aspirin at the dose of 75 milligram at bedtime. Amlodipine I continued and started warfarin 1 milligram once a day. Then I added tramadol little bit in a more frequent dosing, like 50 milligram QID and paracetamol 650 milligram QID and a tablet of lorazepam to have a good sleep. Next slide. So, but thing is that with all this, above measures, just pain relief was only 50%. He came day before yesterday. Only 50% relief in pain, but he's much happier because he could have this much of relief, which he did not had earlier. Sleep is obviously still disturbed because he often feels that there is some jerky movements while he sleeps and he has to wake up and massage his limb and like this, and the claudication still persists. Still, he has to take some rest after walking for a short distance. Next slide. So this case which I have, and my questions are that whether just to know whether am I giving the right medication to this patient. Medication can be added to make him more pain free, to make his quality of life better. Any further pain reduction is possible or not, to give some any intervention or further evaluation for this patient. Any dietary restriction, any exercise or physiotherapy is needed for this patient. So these are my questions which I need to know. Thank you very much for your patient hearing.
So thank you, Dr. Iqbal. I would ask anybody to comment or help Dr. Iqbal.
Can I speak?
Yes, please.
Yeah. So see, the thing is, I think he was keen to kind of look at whether interventions help, because today's topic was interventions. The only thing which is going for this man is that small little non-healing ulcer in his digit. Which is a point of where you might think maybe it might help because it's not a huge ulcer. But if you look at all the other issues, I think he's a highly unlikely candidate for any interventions for the following reasons. First, there might be an element of neuropathic pain to his condition. It is not purely ischemic or vascular pain. And if it is going to be neuropathic pain, then the intervention won't necessarily help. Which also brings to the point B in that same thing. If we suspect neuropathic pain, then we can add neuropathic pain medications like gabapentin, pregabalin, amitriptyline, nortriptyline, duloxetine. You have a whole list of medications which you could possibly use. So that is from a medical perspective. The second point is this man has a significant claudication pain, 50, 100 meters, and he has to stop. Now, doing an intervention will not help his claudication. The only thing which will help is his ischemic wrist pain. It will not help his claudication pain. The other issue, which is a red flag for me or sets the alarm bells going, is it is bilateral. Now, if you want to do a bilateral lumbar sympathectomy, then it should be kind of entirely justified. I know this gentleman is 69 years old, but still you have this problem with retrograde ejaculation and impotence and things like that. So unless if it's the only thing you could do to help his pain, then we shouldn't be offering a bilateral lumbar sympathetic block. One other thing to think about, because it's a very interesting observation, it's nice to see the photograph as well, showing the thickening of the nail and the color changes. Okay, color changes you will see vasculopathy, but the thickening of nails, the atrophic changes what he was talking about. Also gives us a little pointer. Apart from neuropathic, it can also be a complex regional pain syndrome. It could be any insult which can trigger off CRPS. So it could be possibly one of those. But if it is CRPS, then it is also likely that a sympathectomy might be useful. Okay, and looking at the Doppler results and his own pulse oximeter observations, it looks like there is very minimal blood flow to the peripheries. Actually. So it will be useful to measure the blood pressure at the calf and then the ankle as well as the brachial plexus to see what his ankle brachial pressure index is. If it is less than 0.3, then again it is unlikely to benefit from the interventions. It's also interesting to see. I mean, there was no mention in the case reports, but it would be interesting to see whether there is any posterior tibial pulse. He's mentioned clearly that there is no dorsalis pedis pulse, and the pulse oximeter was also not picking it up. If there is no posterior tibial pulse as well, again, it means that there is extremely limited blood flow into the peripheries, and this ABI, the ankle brachial index, is going to be less than 0.3. So again, a sympathetic block is unlikely to be of help. And one other reason why I wouldn't want to offer him a sympathectomy, particularly bilateral sympathectomy, is he is on anticoagulants. Okay, he's on warfarin and he's on aspirin. And I mean, we can always convert it into low molecular weight heparin and get the procedure done, but it needs a little bit of tampering with those medications. So at this point in time, I think particularly for this particular patient, I think a medical management would possibly be ideal compared to bilateral sympathectomy, is my opinion.
So what's your experience in managing pain of POVDs with our usual maybe opioids?
You're asking me?
Yeah. Because we are seeing a lot of POVD patients.
Yeah, with opioids, yes. See, they seem to work pretty well, actually. If it is pure ischemic pain, not much of neuropathic pain component, it is pure sort of ischemic pain. The opioids seem to help, not to the extent that it gives 90-100% pain relief, but to the extent that it makes their life a little less miserable. I mean, opioids, we typically use morphine, and these patients go on to have the opioids at least for a few months before their pain starts settling down, or they end up with an amputation. So opioids is an extremely good choice, or particularly in this patient, which Dr. Iqbal presented. I think that would be my next sort of line, actually, in addition to the neuropathic pain medications. Because the neuropathic pain medication, even if he starts it now, it's going to be a week, 10 days before it starts working. But opioids is going to be quick acting. So I would have him on both, actually, both the opioids as well as neuropathic pain medications together, and give some time for the neuropathic pain medications to work. But as I said, these medications have their limitations. Opioids do not necessarily work brilliantly in vascular pain. I mean, we have to give him a realistic sort of ask him to be a little bit more realistic with his pain relief. Maybe it is not possible to get 80, 90, 100% reduction in pain, but maybe we can make your life, a little bit better with the opioids. But definitely there is a cost for opioids in there.
Yes, madam.
See, I missed it, but was there any allodynia or dysesthesia, that kind of sensations were there in this patient? I mean, I'm not sure whether I heard it or not, because then that would be also more suggestive of neuropathic pain. So I just wanted to know, did he have any abnormal sensations in his feet?
Actually, I forgot to elicit the abnormal sensation. There was no loss of sensation, madam. I just touched, he was telling that there was no loss of any sensation. Actually,
but he didn't have pain, no? When you're touching, there was no pain or any abnormal sensation?
As such, there was not, when I touched the limb, there was no pain. Pain was only during the time of walking, madam.
Okay.
During the time of walking.
Dr. Vijay, don't you think that is a good negative history for neuropathic pain? Like, I mean, neuropathic pain is, I mean, typically
seem-
you'll have these dysesthesias, right? So then will it again tilt the tables more towards an ischemic pain rather than a neuropathic pain? That's my question.
Yes, I mean, there was also mentioned that he's getting this sharp shooting pains, though he does not have evoked pains like allodynia or hyperalgesia. He's getting these sharp shooting pains, particularly at night time, going down his legs, which is spontaneous. So we can't sort of rule in or rule out neuropathic pain. I think we can only give them a trial of, one interventions, if at all we're going to think in terms of interventions, which is going to be somewhat useful for this patient, particularly if we can optimize his coagulation profile, is to do an epidural, because it's going to work bilaterally and you can leave the infusion running maybe for a week, 10 days, just to buy some time. So that is a very valid sort of an intervention option available for this particular patient. Not the sympathectomies, but doing a neuraxial technique.
But he would most definitely benefit from your anticonvulsant and antidepressant medicines, because it's a burning kind of pain. So I think that should definitely be added on in the video.
So in this patients, from the appearance of the foot, as Vijay told, it looks like some CRPS along with POVD with the ulceration. So Iqbal, is there any history that you could elicit from this patient regarding CRPS?
CRPS. Now it's going to be tough actually, because see, the CRPS, you look for a few things. You look for sensory sort of symptoms, which is things like allodynia, hyperalgesia, spontaneous evoked pains. You look for the sensory symptoms. In CRPS, you also look for motor symptoms like dystonia, tremors, contractures, which he doesn't have at this point in time. So apart from the sensory motor, you also look for vasomotor changes, which he has actually. That redness, that swelling, the vasomotor changes. The other thing which you look for in CRP is the pseudomotor changes, which is kind of looking at the sweating and things like that. So that we could possibly do with a clinical examination. But he also has the atrophic changes, which you would typically see in CRPS, like the hair getting brittle, or it getting softer, the nails getting softer or harder, and all those things, given his kind of ongoing sort of clinical scenario. But it is something which I'll have in the back of my mind actually. It might as well be CRPS. However, if it is CRPS, then the treatment for that is exercises. I mean, nothing else. You just provide pain relief and ask him to exercise, move his ankle, move his toes. But this man is not in a situation where he could do any of those, because reading the Doppler is like reading a horror story. It is blocked right up from the aorta down to the posterior tibial artery, it is yes, I'll have in the back of my mind, but it is not something I will act upon yet.
Would CRPS be bilateral? In this gentleman, he had pain in both legs.
We can get sometimes we can get bilateral. Yeah. It is typically unilateral, but sometimes you do get bilateral CRPS as well.
Anybody else? I know that some of the centers in this audience get many patients with POVDs, and we tend to use opioids, and mostly this we will start with tramadol, and then we look on to morphine. And what happens is usually these patients have many comorbidities, and they doesn't have any interventions like amputation or grafting, so vascular grafting. So what happens is these patients will continue to take opioids for a long time. So this is one thing which I am a little bit anxious about. So what's your opinion regarding this? Dr. Vijay, have you had?
Sorry, Sunil, are you, Dr. Sunil, are you asking me or is it for the audience?
No, anybody can. Yeah.
Yes, okay, that's fine, thanks.
The use of opioids for chronic non-cancer pain is a little controversial because this is a little indefinite, but although people are using it, but I think it has to be done with caution. That is what I feel, because this is going to be an indefinite thing. So, I mean, it's been used more and more in Western countries, but in India, I don't know how often we give for chronic non-cancer.
I think Madam's making a very, very valid point, actually, when it comes to using opioids in non-cancer pain. Typically, we never use opioids in any of the non-cancer pain patients, but this is more like an acute on chronic situation. This guy presenting with acute ischemic pain. And if there is one situation where I would kind of think in terms of using opioids, it will be his situation. It's not that we regularly use it in non-cancer pain, but this is more like I would look at him like someone with a fractured arm or someone with a acute abdomen with a laparotomy done, just to get things quickly under control and maybe wean it off as quickly as we can. So I think that would be my thinking.
Okay. What's the role of NSAIDs in ischemic pain? POVDs.
NSAIDs in this patient?
Not in this patient.
Anti-inflammatories.
Generally.
And anti-inflammatory agents. I'd be extremely careful using it in this guy. Yeah, because he's got sort of atherosclerotic plaques sitting in his aorta. I'm pretty sure his renal artery is gone as well, because we haven't actually scanned his renal artery. I'm sure that is atherosclerotic as well. And given his age, which is kind of touching 70, and given his history of vasculopathy, which is all sorts of atherosclerotic plaques sitting everywhere, he's a sitting duck for a heart attack or a stroke if you're going to start him on anti-inflammatories. Yes, maybe 10 days, but if that pain is going to last longer, then it is not something I would think about for this patient. Maybe for a day or two just to try whether it works, but I would like to stop it as soon as possible, if at all I'm going to start, because it will be very, very it'll be tricky. It'll be tricky to use anti-inflammatories, particularly in this patient. I'm not talking about general sort of vascular pains and whatnot. In this particular patient, he's elderly, he's got significant atherosclerotic plaques, he's got other risk factors as well. So we might as well kind of damage his kidneys or give him a heart attack or a stroke with anti-inflammatories, particularly long-term anti-inflammatories.
Yes, Dr. Garu.
Sir, I wanted to ask you about your protocol for stillate. How do you go about if you need repeated stillates or you go for radiofrequency? What do you prefer and why?
Yeah, this was a question which they asked earlier. So if you're going to do a chemical neurolysis and if the pain comes back, will you repeat it? Was the question what Dr. Sunil asked earlier. The other sort of
not
half
chemical,
of the answer, I think it might answer both Dr. Sunil's. Okay. If you're going to do a radiofrequency treatment, you can repeat it. You can repeat it because it's a point burn on the sympathetic on the stellate ganglion. It's a point burn on the lumbar sympathetic plexus, which means when the nerve regenerates, you can always go back and do another point burn. Whereas if you do a chemical neurolysis, the whole tissue around the area gets fibrosed, and the repeat injections that we do won't necessarily be as effective as the first one. So yeah, if you do have access to radiofrequency, I think this is probably the way to go, particularly for the stellates and the and the lumbar sympathetic plexus. Yeah. But obviously, you have to take into account the availability of a radiofrequency machine, the cost of the procedure. So all those things come into, whether it is cost effective, because it is not necessarily better than a chemical neurolysis, but when it comes to cost effectiveness, it is at least 2-3 times more expensive than a chemical neurolysis.
I was particularly referring to whether to give a permanent harness to the patient.
Permanent harness,
do you
yes.
want to?
See, again, it is a risk benefit. You're kind of moving on from cost benefit to risk benefit. Now the thing is, it's a very simple equation here. If you get a consent saying that you will look sexy with the one eye closed all through your life, or for the next 3-4 months, with a permanent neurolysis with the harness, and if the patient accepts being sexy with a little less pain in the arm, then it is something which is acceptable. It's been documented that this harness will be there for quite some time, and we are doing it just to relieve the pain. And we always explain to the patients. I have done chemical neurolysis, stellate neurolysis for someone, and they said, it doesn't matter how I look, but I want my pain to be less. So as long as it is documented and the patient signs for it, it's fine. And the harness also, it recovers after a while, actually. For 2-3 months, it's going to be ptosis. That's about it.
And what was your protocol for cardiac angina, refractory angina pain?
Okay, so refractory angina, what we do is we don't do the radiofrequency ablations, we don't do the chemical neurolysis. What we do is we just do the repeat stellate ganglion blocks. So we put in I used to put in large volumes of 10-15 ml in that space. And then what happens is typically these patients keep coming back every 3-4 months for a repeat block. And this is not, I would like to make clear for everyone, this stellate ganglion block for angina, it is not for unstable angina, it is not for vasospastic angina, it is not for acute angina. It is for chronic, stable angina. They have multivessel disease or single vessel disease. It's been there for quite some time. They've done the stents, they put in the stents, they've done the bypass, still not settling down, still they have this pain, and it's chronic and it is stable, is when we go and do the stellate ganglion blocks for the it is done on the left side stellate ganglion block. And not everyone benefits from it. So if you do it for about 50 patients, maybe 10-15 might benefit from it. And if the ones who do benefit keep coming back every 3-4 months for a repeat procedure, that could go on for a very, very long time, 5-10 years. Yeah.
Thank you, sir.
Thank you.
Any more questions? I think Rajashree Madam has a question.
Can you hear me? Can you hear me, Vijay? Yes. Now, Vijay, just wanted to ask you, do you have any experience in using ketamine in patients with such pain? What is the role of ketamine in management of ischemic, probably with a complication?
Is anybody asking question?
I'm not sure where it's coming from, but I think someone's asking about it.
Can you hear me? Sunil?
Yeah.
This is Dr. Rajat here from GK.
Yes, please ask.
My question is to Vijay. Vijay, just wanted to know if you have any experience in using oral ketamine in patients with ischemic and neuropathic pain in such patients. What is the role of ketamine? Thank you.
Ketamine is not, it won't be at the top of my list actually. because ketamine also causes vasoconstriction. So if someone is a vasculopath, I don't want to go and start them on ketamine. But I mean, if someone's on opioids and the pain getting worse, and you go up and up and up on the dose of opioids and getting desperate, then it is something which I would think about, but not as the first line drug for this particular problem. Because I mean, one of the properties is tachycardia and hypertension with ketamine.
Dr. Mary was going to say something. No. Okay. Then I think we can stop this session. And thank you, Dr. Vijay, for joining us and being with us for 1.5 hours. And next session is on intervention in musculoskeletal pain, and it will be on 8th December. So let's sleep and see you all on 8th December.